all too often, I think we don't recognize how much medications can be a barrier as far as administration of them. We know that people who are at end of life oftentimes change in their ability to swallow and process and handle medications, which can lead to unintended things such as failed efficacy of the drug or even potential problems like choking on the medications. And so the Macy Catheter has given us an alternate option that is extremely effective, extremely easy for the patient. I have definitely seen and borne witness to the rapid rate of onset, the high nature of perfusion, and the visa vasorum in the area of the rectum where the microenema is going. It is very predictable, which is in stark contrast to the sublingual route, right? Because we know that, for instance, morphine, liquid morphine that we use a lot, we know that medication does not get absorbed sublingually at all. And I see evidence of that. People tell me, oh no, it's absorbed quickly because it's sublingual, and yet the patient is still telling you they hurt 45 minutes in. It's just logical that it's the best way when you're having trouble with oral administration to give a medication. Respiratory noise is not a pleasant sound. When we hear respiratory noise, and we know that's because people are not swallowing and the gag reflex is altered, the one thing that logically leads to that most of the time is the liquid medications and crushed medications we're trying to give. The loss of dignity in watching somebody and listening to somebody go through that far trumps and outweighs theoretical loss of dignity of something that they don't even know is there because they can't feel it. Unsure when they start to hear about a rectal route, the minute that it is explained and then utilized, I've gotten feedback 100% of the time that it works great, not just from the family, but from those patients that actually are able to speak to it, that they don't even notice it, that they love it, that it's taken a lot of burden off. And in fact, that is typically the conversation. You have no idea how much burden it offloaded from us and having to give these medications because it was so difficult and it was hard to see them having trouble swallowing them and not knowing if they got the whole dose in them. We want to promote comfort and dignity at end of life, and it has helped in both of those areas. New things are often hard for us, both when maybe medical evidence points towards a different therapeutic option than maybe what we've practiced, or when something novel comes out. New things can be groundbreaking and they can be revolutionary. And ultimately, I think too often we dismiss things by the newness, or maybe it sounds too different from what we've done in the past. Really, the proof is in the pudding when the patient, who is the center of care, tells you they are glad that they did something and it is working well for them.